All right, thanks everyone for tuning in. Dr. Tom Nabity,
Dr. John Santa Anna, good evening.
Both want to do a little introduction of who we are for those of you who might be turning in or being introduced to us for the first time. We're physical medicine rehab specialists, interventional pain specialists, which is essentially a non-surgical orthopedic specialist able to evaluate pain conditions such as knee pain, shoulder pain, neck pain, back pain, and offer the gamut of treatments from non-surgical treatments as well as minimally invasive surgical options, referring to our orthopedic and neurosurgical colleagues when necessary for surgical intervention.
And then we expanded our scope of practice to now specialize in regenerative medicine as well. Both Dr. Tom Nabity and I, we took extra education and curriculum as far as learning how to advance the field of regenerative medicine and really master on how to treat conditions with regenerative medicine.
Yeah. So with that, we'll kind of jump into tonight's topic. We wanted to touch base on how we approach patients who are coming in to see us with back pain and sorting through the different sources that might be causing that back pain, and then the different treatment options. So with that, I guess I'll turn it over to Dr. Santa Anna. If patients coming into you with back pain, what are some of the key historical indicators that one thing might be causing the back pain over and over?
Yeah. So when we kind of look at somebody with back pain, it's a pretty broad topic because there's a lot of things that can cause back pain. The most easier ones is if you know exactly what causes something that's traumatic, right? So something that you know from a slip and fall injury, this happened about a couple of weeks ago and you still have that, versus something that's been around for such a long time, something that's more chronic and not resolving. Most of the patients that we've seen here, they've already tried conservative treatments like physical therapy, icing, heat, and non over-the-counter pain medications. That's something that they've tried before. But if not, that's something we can discuss here. So looking at the different parts of back pain, we kind of look at it as far as how does the back pain affect you? Is it more pain related to the area in your lower back? Is it a pain that radiates to different areas of your back or different areas of your leg or your hip or your thigh? There's different kinds of pains where it can affect other neurological functions as well, like loss of bowel or bladder or weakness or numbness and tingling going down your leg. So when we talk about back pain with patients, we really try and figure out what's the chronicity and how acute the back pain is. How is the back pain affecting you? What makes it worse? What makes it better? And other parts of your body is also affected with this back pain, right?
Yep. So kind of with that approach, give me some sources or what are some of the main sources for people's back pain.
Yeah. So I guess the most common source of back pain is your more typical mechanical back. Over the weekend trying to put up a fence, that's your mechanical back pain issue. So a lot of times just a little bit of rest, conservative management, ice, heat, stretching, things like that can help with that. Usually nothing much comes off of it. It gets better over time like any other injury. So those ones are pretty easy to spot. So with those types of injuries, you don't really want to over-treat those. The big thing about that is just try and rest it, do really conservative type things, and for the most part, it'll get better. It gets more difficult when you've tried all of that already and it still hasn't gotten better. So what would you?
Yeah. Advanced imaging always helps. Once something has failed conservative treatment, our physical exam skills are good. We can oftentimes elicit where we think it's coming from a disc or where we think it's coming from a facet joint or SI joint or whatever the source might be. But to know exactly how severe it is or how significant the problem is, advanced imaging, in particular MRIs or CTs, are extremely helpful. Once we have those results, putting that whole picture together and coming up with a comprehensive plan. I spend a lot of time talking to patients about the traditional pain management pathway versus a regenerative medicine pathway. Not that they're completely independent of each other. You can do some of each, but there is the idea of the pain management pathway is really more mask the pain, try to buy some time, exercise, and see if this problem just goes away on its own. Versus a regenerative medicine pathway is, hey, we've already tried that. It's not going away on its own. And why don't we try to fix the problem, regenerate the tissue rather than just mask it with pain medicine?
And I think that's one of the main reasons why I really like our practice, is because we can offer all those options. We don't just offer your traditional medical treatments that everyone is aware of, such as nerve blocks and steroids and other pain blockers too, but we have this extra tool that we could use to actually try and resolve your pain. So it gives people a lot of different options, and depending on where you are with your pain and the condition, then you can decide for yourself which is the better way to go.
So just briefly, if we could take a few minutes to talk about those pain management options that we do offer here. Mm-hmm. While the bulk of the time tonight, I would like to devote towards the regenerative medicine. That's really what makes us unique and something we offer that most other clinics can't. Tell a little about how the cortisone injections work, when you're injecting them, what are some of the targets you might go after, and what sort of treatments might that us down?
So the use of steroids and injections has been kind of the staple for pain management for a really long time. So the idea with that is you identify the sources of pain, and being able to identify the sources of pain is probably the biggest part of the treatment, right? So we have to find exactly what the source is. So somebody who's skilled in the physical examination, being able to kind of put together all the symptoms and findings on the physical exam and correlating that with what you see on imaging, such as MRIs and CTs and X-rays, and then finding that localization of pain. So from there, then you can target those areas with some anesthetic to block the pain, a little bit of a steroid to reduce the inflammation. The most common treatments that we do with a steroid injection would be something called an epidural steroid injection. So as the name implies, it's an injection into the spine with the idea of putting the anesthetic and a steroid right in that area where you have that pain generator. We do this injection under X-ray. It makes it very safe to do, and it gives people a lot of really good relief. So it gives them an opportunity to at least do some physical therapy, buy some time, get you back to work, or do whatever event you have to do. The other areas that we do injections also would be on the facet joints. So the facet joints is where the juncture where the bone above and the bone below meet in your spine. So that could also be another source of pain. And the other more common one is your SI joint or your sacroiliac joint. Essentially, it's a joint where your pelvis actually meets your spine. So it's a very common area to have pain as well. So being able to distinguish where the proper source of pain will help us pinpoint where to put the right medication and to get your path feeling better.
Yeah, so if we're successful in the right diagnosis and putting the needle in the right spot, oftentimes the pain goes away, and then rehabbing and going through an exercise program to stabilize that joint. For example, the SI joint, if it's a unstable SI joint, working on those tendons and muscles that cross that joint to stabilize it so it stops moving and so the pain doesn't come back. However, in the event that the pain does come back, classically the next step would be a surgical option, and instead of a traditional surgery where we're cutting tissues out or screwing bones together with fixation, surgical fixation, there's the option of regenerating those tissues that have degenerated over time, whether they be ligaments or cartilage or intervertebral discs in the case of a back pain patient. We can take patient's own cells out, concentrate them in our lab, identify that we have a sufficient quantity of cells, and then target those cells directly into the tissues that we want to regrow, those tissues that are either herniated in the case of the disc or overly stretched and lax in case of a ligament. And we can target all those specific areas to regenerate and regrow collagen, which is the protein that gives our cartilage, our tendons, our ligaments structural integrity. That's the overall process by which all of these regenerative medicine injections work, with the difference being potency, whether we do something called a prolotherapy injection, a platelet-rich plasma injection, or our strongest injection, the bone marrow concentrate stem cell injection. They all stimulate that growth and healing process through the regeneration of collagen.
Yep. And then the approach to regenerative medicine is also different from the approach to traditional medicine. With traditional medicine, as we implied earlier, you find the source of the pain and you inject that with a pain blocker, which is usually a steroid or an anesthetic. With regenerative medicine, it's not a pain blocker. So with regenerative medicine, we tend to look at structures as a unit. And the idea is you're trying to find the dysfunction in the unit, whether it's in the spine or in the pelvis or in the hip when it comes to the lower back. and try to find the reasons why it's not in balance and why it's not biomechanically sound. And we try and address those, like Dr. Nabity said. You want to address those ligaments, those tendons, those joints that are being affected because of that instability. So you're not just targeting the pain, but you're targeting the source of the pain.
Yeah, and then the structure as a whole is oftentimes what I bring up when we're doing a pain management pathway or really trying to pain management injection. We want to target as few areas as necessary so we know specifically what's causing most of the pain. When we're treating a patient with a regenerative medicine idea, we know it's all the ligaments and tendons and structures that support maybe that disc or that facet joint that have degenerated over time. So we don't just want to target simply the disc or simply the facet joint, but all those other structures and really treat the spine as a whole, and that segment as a whole, so that we regenerate everything that has followed through that degenerative cascade.
Yep.
So a patient I had this evening, younger, mid-30s patient, very active. She's got a large disc herniation on her MRI, and it's a single level, L4, L5. Radicular pain, classically, been through the epidurals, been through the physical therapy, really has exhausted the pain management process and has been offered surgical treatment.
Yeah.
Had a consult with her tonight. Be kind of curious what your thoughts are on someone like that. How would you approach that? What are the kind of pros and cons that you might discuss with the patient? Because I thought it was a great discussion that would be appropriate for tonight's.
Yeah, no, it sounds like it's a really good case. So somebody who's young, is 30 years old, you definitely want, first off the bat, kind of try and steer them away from surgery, right? Because the thing with surgery, it's such a final thing. Right? You can't turn back from that. Once you have surgery, there's no reversing back to not having surgery. So for somebody that young, you definitely want to give them all the chance they have in order to not have to do that. But if they have to, obviously that's the best option. That's what we'll go for. But for this one, what I look for patients like this, and you can kind of add in, is, what kind of symptoms does she have? As long as she doesn't have what we call these red flag symptoms, where we would know right away that you're a surgical candidate, then we can try doing things like regenerative medicine and other non-surgical options. So things like, does she have loss of control over bowel or bladder? Does she have paralysis in the legs, or things like that, which that's a more bigger neurological issue, or a spinal cord impingement or something like that really necessitates surgery.
Yeah. So no reflex changes. Very slight decrease in strength with dorsiflexion, so going up on her toe. Otherwise able to do her exercise routine that she wants, other than running. She can't run, and she would enjoy running. No bowel bladder incontinence, no other paralysis.
Yeah. So if she has no other contraindications, like she's a fairly healthy person with no other comorbidities that's going to prevent her from having any, advanced or more advanced procedures, I would definitely lean more towards advising her to go into the regenerative medicine route, either with PRP or stem cells, because of her young age, she could probably do well with both. But depending on how big the size of the herniation is, how much degeneration is there, typically I would recommend bone marrow stem cells over PRP over in these cases. But again, it all depends on what her MRI shows and kind of how her symptoms are altogether.
So I recommended bone marrow for her. Yeah. If you could touch base a little bit, the difference between PRP and bone marrow, especially when you're looking at structures like a disc, and a vertebral disc.
So PRP is derived from the blood, so it's platelet-rich plasma. So in simple terms, the PRP, you're essentially using a marker to attract healing factors into the area. So you extract that from the blood, and then you inject it right into the area you want to be healed. The advantage of PRP is, one, it's easy to do. It's really not painful. It's just a blood draw. And then you process in the lab. The healing time is fairly quickly as well compared to any other medical or surgical procedures. And it's fairly easy to do. The downside with PRP is that it's always going to rely on how the vascular system will be able to deliver proteins and growth factors and healing cells into that area. So a structure like the disc, where it's not very vascular, that means it doesn't have a really good blood supply. Even if we put PRP on there, if it's not going to be able to to bring in or draw in more of these healing factors in there, that becomes like a limitation too. Yeah. And I think that's when things like bone marrow stem cells has an advantage, because you're directly bringing it there.
That's exactly how I explain it to patients as well. Not to get too much into the weeds, when we explain this to patients, the easiest way to say it is we're taking cells from the bone marrow and we're putting them in the disc, and those cells we're taking from the bone marrow are going to become disc. In reality, those cells that we're taking from the bone marrow are stimulating your disc cells to grow and divide and become more disc cells. It's the same end result, in that you get more cells in your disc and collagen production from those cells, and a stronger disc and a more flexible, robust disc. But the process of doing so involves the MSCs, or those stem cells, and if they don't have a highway to get into a vascular system, a highway to drive into their end target, the result just isn't as profound. So, no, that was what I recommended for her. We talked about the different types of discectomies, but in the end, wanted to go with the bone marrow stem cell first. Yeah. You don't burn any bridges. That's one of the really nice things about a stem cell procedure is we're not removing any tissue. These cells do a great job of regenerating. They don't necessarily dissolve or cut out things like bone spurs. But if you can regenerate the tissue and you can get the pressure off the nerve, and you can create enough space in there for the pain to be improved, if not resolved, we can avoid surgery altogether. It's oftentimes a tough call, though, especially on these larger disc herniations, whether we should operate first and then do regenerative medicine afterwards, or regenerative medicine first and then, if necessary, operation after. And if we had that crystal ball, that would come in handy. But we do our best to prognosticate based on our experience. And fortunately, between the two of us in particular, we have more experience than I think anyone in Michigan, certainly, doing these types of procedures. And we've gotten much better at predicting who's going to be a good, successful candidate, who's not. And I think we both pride ourselves in not telling everybody that, oh yeah, you should do stem cells. Right. If we really don't think it's going to be a great option for you, we try to make a recommendation based on outcomes. Outcomes is what our business and our reputation depends on, and I think that's very important for us to make sure our patients are getting great outcomes. Yeah,
and as good as regenerative medicine is, and I always counsel my patients, it's never ever a sure thing. Like, and nothing in medicine or even nothing in life is a sure thing, but we can at least predict with a high level of certainty how it might turn out. I mean, any physician can say this. We can pinpoint and target and treat the area as perfectly as you can, but once we're done and it's your body's turns to fix it or take over and then regenerate something, that's all a variable that we can't control, unfortunately.
Yeah. And we are doing we're tracking our outcomes. So we have real data that we can now start sharing with our patients on how people we've treated, how they've done, what percentage of outcomes, what improvements in pain scores patients are getting. So it doesn't have to be just our gestalt and our experience and what we feel like people are telling us. We actually are getting and tracking long-term outcomes up to a year out, how people are doing, using a validated patient registry.
Yeah. And the thing about like this patient registry, it's nationwide, right? And it's spread out between physicians and clinics. It's very similar to ours, where they do high-level regenerative medicine. What we process in our lab, or we count our cells and we document things very well, and we kind of look at things in a functional way as well. So it's not just it's a really robust patient data registry, and we're actually really proud to be invited to be a part of it.
Yeah. So I guess maybe just a second to back up and just review, our approach to people that come with back pain is really, step one is proper diagnosis. What's the source of your pain? Really figuring that out. That's combining your history, your exam, your imaging. And then at that point, maybe we know with a reasonable amount of certainty, 90+% where your pain's coming from. Maybe we still don't, in which case we'll use some of these pain management injections to get a diagnostic response. So yes, that's mainly where your pain's coming from. And then make further decisions from there. Do we start now to do regenerative medicine and try to regenerate that tissue that's causing your pain, or do we go more of pain management surgical route and block the pain, remove the tissue to see if we can buy you time before that pain just goes away.
Yeah, and the last option is, we look at a patient and do the evaluation, and it looks like, you know what, I think you're a better surgical candidate than trying all these conservative things. So, and we've done that before. And I think one of the things that I think we're proud of as a group is that we've been very good at being able to identify patients who are going to be good candidates, and also good at telling patients that, hey, look, I think you've done everything you could have done correctly, but you're at the point where I think surgery is going to be the best option for you.
Yeah. We got a few minutes here left. If you're to leave a patient, someone's watching us tonight, maybe that can't, if you live in the Michigan area, we would love to take a look at it. We do telemedicine visits. Even if you're long distance, we certainly see patients from quite a ways away. But let's say you are a patient that can't necessarily come and see us. If you're to see a regenerative medicine specialist, there's a few things I would recommend asking is, what their background is, making sure they have a background that's orthopedic based, that has guidance based. So interventional pain physicians in particular are well trained in this, orthopedic surgeons, spine surgeons, sports, family practice, sports medicine, people that have that kind of background, the type of injection they're going to give you, that there's some sort of analysis that's done. So one of the biggest concerns and limitations within the regenerative medicine space is not all clinics will do a cell analysis to know exactly what dose essentially you're being injected with. With PRP, for example, how many platelets? When we take your blood out and we count the platelets at baseline, most people's baselines are somewhere around 200. If we're to concentrate and to get that to 300, technically we've created platelet-rich plasma. In our lab, we count the cell counts after every sample, and we almost always have above 1 million, and sometimes super concentrate into the 3 and 4 million range. Well, there's a big difference between 300 and 3 million. So to know the difference in what you're being injected with, I think is really important. And then lastly is guidance. No matter how good we think we are with our needles, if we don't use guidance, once we poke the skin, we can't see the needle anymore, unless you're using an X-ray or ultrasound machine. Yeah. So know their background, ask them how they know what they're injecting, and do they use any kind of guidance. Those would be the 3 things I think are most important in making sure you're getting a good quality regenerative medicine procedure. Yeah,
I think regenerative medicine is a great way to treat musculoskeletal, joint and spine issues. And I think the more that practitioners are willing to embrace it and do it the right way, and refer to doctors who do it the right way, then it's going to have a lot bigger reach and help a lot more people.
Yep. No, and that's the key thing, is the right way. And that's still up for debate. But I do think what we're doing here is cutting edge, and both Dr. Stanton and I stay up to date on the advancements that are being created within the field. We go to conferences and do a lot of continuing medical education to make sure that we're offering our patients the very best that regenerative medicine has to offer. And we'd love to take a look. If it's something you think we can help you with, feel free. I think our website is posted on this. If not, it's regenerativemedicinemichigan.com, and our phone number 248-216-1008.
Yep. So we'd be glad to see you. Any questions or anything like that, you can shoot us an email, drop a note on Facebook or something like that. We usually check it pretty frequently. Good to hear from you.
Yeah. So we appreciate those of you who tuned in, and if we can answer any questions, feel free to reach out to us, email, phone call, however is the easiest.
All right. Good night.
Thank you.